So my name's Dr. Claire Searle. I'm one of the consultants based here in Nottingham, and I head up cancer genetics with my colleague Rachel Harrison in the department. This is a talk that I've given locally in our department when sort of CanRisk started to be introduced, and that I've adapted over the years. I'm not affiliated to CanRisk. I don't have any particular links to them apart from the fact that I use their software and email them occasionally. The knowledge from this is based on the information on their website, conferences that I've been to, and what I've picked up from using the software. So and I was asked to do this because we thought it would be helpful to a wider audience. So in this talk today, I'm going to talk a bit about what CanRisk is, what data you need to input into it, how to build a pedigree or family tree into the software, how you can calculate the variant or sort of mutation carrier probabilities and breast and ovarian cancer risk. I'm going to talk about how we save the files and how you might want to save the files locally to you, and potential pitfalls of using CanRisk. And I'm going to provide a few examples just to try and work through that. If anyone's got access to CanRisk already, it's worth just uploading that onto your computer at the moment. You can have a bit of a play around as we go. And is there anything else particularly that people would like me to cover as part of this? Really? Okay. So we've got, I'm just having a look at where you all are around the country. So we've got Nottingham and Cambridge, got Kingsmill. Is there anyone else from anywhere else around the country that's attending? No. And are you all either in a breast cancer family history type setting or clinical genetics? Is there anybody from anywhere else, just so I know how to pitch it? So Graham?
Hi, Claire. Yeah, so I'm a genomic practitioner with the East of England Cancer Alliance, and I'm coming along for a general overview. And so
yeah.
This is going to be breast focused. What about prostate? And just for my curiosity.
So yeah, I can mention that. So you can put prostate cancer into CanRisk, and you can use it to calculate some mutation probabilities of picking up a variant in specific genes, but it doesn't give you a prostate cancer risk as such.
Yeah, because I just noticed that it's in the guidelines, isn't it, for using CanRisk for generating a score for prostate,
yes.
to qualify for the can't remember the R number, but for the prostate. So I think I'm mindful that in the future we're going to be supporting teams that might be using it, or we might be using it for that purpose. So not expecting you to cover it today, but just telling you where my point of interest is.
Yeah, and that it's really difficult with prostate because the Lynch genes, which are on the prostate panel, are not on CanRisk. So when you're using CanRisk, it's going to underestimate. We have got some local guidelines, actually, Graham, that we use a bit when we're trying to work out who's eligible based on family histories. I can't remember them exactly off the top of my head, but I can email them to you if that would be helpful.
Thank you.
I can find them and email them across.
Thank you.
Just make a note of that. Is there anything else that's slightly unusual that people want to mention, just to make sure that I cover it? No? Okay, well, I'll make a start. Feel free to just put your hand up, ask questions. I don't know if Maz, if you can keep an eye out on who's asking questions, just in case I don't see them when I'm doing the presentation, but feel free. I want this to be sort of a two-way if possible. So what is CanRisk? So CanRisk is a web-based tool. It incorporates the latest versions of Bodicea, which is a breast and ovarian analysis of disease incidence and carrier estimation algorithm. And you just access it online using www.canrisk.org. And as Maz says, if you go onto their website, you can request a login for it. And they always used to say Google Chrome was the best platform to access it on. Our trust has now stopped that, and we're all using Internet Explorer. It seems fine on there now too. Whenever you're using CanRisk, you always have to bear in mind it's not a perfect tool. It's the best we've got, but it's not perfect by any means. It's a predictive model. It's not 100% accurate. The figures that it gives can quite often seem quite accurate as they're given to decimal places, but they're really not. And actually, if they provided the confidence intervals for those estimates, you'd see that they were quite wide. Always use your clinical judgment when using CanRisk. If the figures just look wrong, question them, go back through, check that you've inputted things right. If they still look unclear, you can always email CanRisk and ask why. Patients should be informed that it isn't an exact science, that the estimates may change due to lifestyle factors or family history changes, or as we learn more about these risks and the data which they use in the algorithm is updated. It doesn't take into account breast cancer treatment. So if your patients have breast cancer and been on tamoxifen for the last 5 years, it won't take that into account. The tool is based on current genetics knowledge. The risk estimates may change, as I said, due to new research. So yeah, it's only as good as the information you input into it, and the patient, if the patient's had an ovarian cancer, it will not calculate the breast cancer risk, and if your patient's had a breast cancer, it will only calculate the contralateral breast cancer risk, and they may still have a large amount of breast tissue on the remaining affected side. We use a standard insert in our letters when we're quoting CanRisk to sort of caveat what we're saying. I've just put it up for you here, and I'm very happy to email that round if anybody else wants to use similar. But we've discussed your personalised cancer risk assessment. We use software called CanRisk to predict a woman's chance of developing breast and ovarian cancer in the next 5 and 10 years, as well as estimating their risk up to the age of 80. This assessment considers your family history of cancer, genetic test results, and also some of the lifestyle and hormonal factors that I asked you about. However, this software does have its own limitations, taking into account only in the information put into the system its current knowledge about risks associated within each gene, and this isn't exact science. The estimates may change due to lifestyle or family history changes, or as we learn more in the future with further research. So I sort of emphasize that because I think it's just so important to know that this is a model. It's not a perfect crystal ball. So the CanRisk tool is optimized to use by specifically in the genetic setting. It's been approved for use by healthcare professionals and researchers in the UK and the European Economic Union. It allows you to estimate a woman's probability of carrying a genetic mutation, calculate her future risk of developing breast or ovarian cancer, and identifies the appropriate NICE screening recommendation category. You'll be prompted when you go in there to enter numbers of different other factors, such as risk factors such as age, lifestyle, hormonal history, genetic test results, and family history. The tool then integrates this information to generate a personal risk assessment. We use a CanRisk additional questionnaire form. So we quite often send this out with a family history questionnaire that just allows you to gather the information on the risk factors before you've got a patient sitting in front of you in clinic. And again, we're very happy to share that if that would be useful to anybody. If you want to be emailed any of these things, just put in the meeting chat that you would like in your email address and I'll send it across to you. Depending on whether CanRisk is looking at breast cancer risk or ovarian cancer risk, they look at different risk factors, and this is just a table summarising some of this. So age of menopause is only applicable to breast cancer risk. Age at first live born, again, it just is taken into account when looking at breast cancer risk, and the genes that are not highly associated with breast cancer, ovarian cancer obviously are not taken into account as well when the CanRisk software looks at the algorithm. I'll just pop those in there. And again, I'm welcome to send this presentation around to people if you want to read through anything in more detail. So this is what CanRisk looks like when you initially go into it. It's got drop-down boxes Once the box is completed, it goes to green, and the ones that still require input are light blue. If there's something that you haven't put in that's essential, it comes up with this exclamation mark in a triangular box. And you run the risk calculation. When you filled in all these sections, you can just press the green button at the bottom. So I'm just going to bring up CanRisk just to talk you through that. But as you can see, it's the screen here that you get to. You can just toggle between male and female. Obviously, if you go onto male, it removes a number of the risk factors. Fill in which ethnic group you are, if possible, the date of birth, how old you are, how tall you are, sorry, your current weight, and as I say, it clicks you through all these different sections. So do you drink alcohol? Yes. And then it will quite helpfully allow you to calculate the units by just asking how many glasses of wine they drink a week or how many bottles of beer, and you can change that from daily, weekly or monthly. In regards to women's health, it asks about when the first period was, have they ever taken the oral contraceptive pill, and then if they have, how many years they've been on it. Have you been on the pill in the last 2 years? If you've been on HRT, you can select how many years, and have you been in the last 5 years. If you don't know what type of HRT it was, it's got this helpful list, so you can pick from the brand name, and that will tell you whether it's a combined HRT or estrogen monotherapy, etc. It asks if your periods have stopped completely. You can fill in how many children you've had. So 1, and then you have to select the gender of the child and the year that they were born. Breast screening, it asks if they've ever had a mammogram and if they have been told about their breast density. That's not something that we can currently fill in about breast density in Nottingham as far as I'm aware, but if you do know that about your patient, it is quite a substantial risk factor in developing breast cancer. So it's normally a BRAD score, and you can fill in the BRAD score there. In regards to medical history, it asks whether you ever had endometriosis or had a tubal ligation, because there are increased risk factors for developing ovarian cancers, so you can fill that in. And it asks about whether you've ever had a breast surgery, breast cancer, ovarian cancer or pancreatic cancer. Obviously, if you filled in men, it will ask that your patient's male. It will allow you to select whether they've had prostate cancer. If they've had breast cancer, it'll ask you the age at which they were diagnosed. You'll note here that it says please exclude ductal carcinoma in situ, and that's the official guidance from CanRisk that you should be excluding it. That would exclude quite a lot of women, we feel, as a clinical genetics community, and therefore we tend to input their age of diagnosis as 10 years older, in order to make sure that it reflects something in CanRisk. That's not a perfect fix, because obviously if you're seeing a patient at the age of 50 who also had breast cancer, which was a DCIS, diagnosed at the age of 50, if you make her 60, then all your risk estimates for the next 10 years are out. So it's not perfect, but can be done if your relative's been diagnosed with DCIS and you know that. Sorry, Anna, you've got your hand up.
I was just wondering if is it the same for high grade DCIS? Do you still add 10 years on?
Yeah. So
okay.
Sorry, I should have caveat that it's high grade DCIS that we add.
Only, okay.
So yeah, only, yeah. If they've had a polygenic risk score, which most of the patients in our area haven't, in Cambridge, you will have some people that have been part of the CanRisk ClinGen study that will have polygenic risk scores. And we should hopefully have a few of those coming back to our department soon too. And then in the last section, it allows you to add the family history, and you can do this in multiple ways, whatever's easiest. So you can either select you just want a first degree, which family history, or you can select a second degree family history, and then you've got something that you can just edit, or you can add the number of brothers, do an option 2 and add the number of the brothers, sisters, sons and daughters, aunts and uncles, and then it will draw you a template based on that. Or you can upload a previous file with the pedigree. Okay, and that's what I've done on this one here when I've gone to family history. Oh no, it's not loaded it. Anyway, I can load that later. So on this example here, it's got the patient here, her partner, a brother and a sister, and you can go in and then edit these. So if the first person to be selected is the one with the arrow. So here you can put in age of date of birth, the age that they were diagnosed with breast cancer, ovarian cancer, pancreatic cancer, put in the pathology if you know it, so estrogen receptors, progesterone receptors, HER2, and those are just selected here on a drop down. That's probably because I haven't actually put her with breast cancer, so I put breast cancer at 25. Then you'll be able to select the estrogen receptors, etc. And then you can also do the genes tested on a mutation search, a direct gene search, absent recent. So I will go through my slides to just talk about the difference between a mutation search and a direct gene test, but it's basically a full sort of R208, or whether they've just had a predictive test, so they've only had the one variant. And then you can put the results in. You can select the same result for all if you want to, or you can just put them in individually. You can then go across to the next relative and put their details in, and then click on the next one and put their details in for their cancer diagnosis, their age. And I just really encourage you to put as much information as you know about that patient. Okay, I'm just going to pop back to my slides now to discuss a couple of other things. I will also mention that you can add other people by right-clicking. Oh, sorry. So these things do different things. So you add a partner by the 2 links. If you want to add a sibling, it's the one across from that. And if you want to add a child, it's the one down from there. And a circle is female and a square is male, which is the standard way that we draw family histories. If you've already got a pedigree and you just want to upload it, you just go to this load button at the top here. And I will we've got ours in so I've just done a presentation example here. So it looks like the document looks like that you upload. If I open it here, that's an example that I've done previously, which I'll go back to after I've shown you some more slides. So as we said, breast cancer is taken to mean invasive breast cancer, and we've mentioned that ductal carcinoma in situ should not be included, although, and I should caveat that, usually said high risk, high grade, sorry, and like many other departments, we add 10 years to the high grade DCIS to put it in. Age limits in CanRisk calculations. So breast cancers diagnosed at 80 or older are not included in risk assessments. That's because they don't have enough data about them, and breast cancers diagnosed under the age of 20 is extremely rare and also not figured into the assessment. So if you do happen to have a breast cancer that's been diagnosed at 19, you're best putting it in at sort of 21, 20 to make sure that it's included in the calculation. If a case of breast cancer is recorded at 18, as I said, you're best just increasing the age to make sure that it's included. If someone has 2 breast cancers in the same breast, there's no way of putting that into CanRisk currently. So sometimes when we do that, we might put the second in as them having a contralateral breast cancer for calculating the percentage chance of finding a variant, but that's obviously no use if you want to calculate their risk of developing a contralateral breast cancer, because it won't give you those estimates. How do you define an ovarian cancer when using CanRisk? So it refers to an invasive epithelial ovarian cancer, so don't include non-epithelial cancers such as germline, and and consider potentially not including borderline tumours as well, as they've not very clearly linked to BRCA1 or BRCA2. In regards to uterine cancers, they should also not be included, including cervical cancer, but do include fallopian tube cancers, any primary peritoneal cancers, or any stick tumours, so serous tubal intraepithelial carcinomas, which is thought to be, I always think of it like the DCIS of ovarian cancer. So it's the sort of precursor lesion to developing high-grade serous ovarian cancer. We've talked a bit through what to input, so I won't linger on that slide. As I say, you can build the history using the different methods that I've shown you. These are the symbols, a bit clearer and a bit bigger. So the chain is to add a partner, the arrow up is to add a parent, the person with the plus by it's to add a sibling, the down arrow is to add a child, and these triple lines are to add a consanguineous partner. So if the partner is a first cousin, second cousin, etc., you can add them in that way. You can also add in twins, either identical or non-identical. If you don't know the sex, there's a diamond that can be used, and then there's female and male. You can add in half siblings by just adding a new partner to your parent, and then adding the half sibling that way. As I say, try and include as much information as you possibly can, because that will just help make the accuracy of the calculations greater. So always try and put in the age or the age of death and the year of birth. If you don't include those factors, CanRisk won't include that person in the estimations. So your best estimating ages. So if you know someone comes to see you who's 30 in 2025 and their grandmother died of ovarian cancer, but they don't know what year she was born, but they know that she was diagnosed at the age of 40, you can make an estimate based on the fact that 2025 minus 30 years for when she was born, minus 25 potentially for when her mum had her, minus 25 for how the date of birth of her grandmother, and I would put that in. It's not exact, but it's better than not including it and the person being excluded from the calculation because of it. As I say, you can add in the gene testing information, and that's got a mutation search, which is a diagnostic whole gene screen. So that's like your whole R208. And the direct gene test is the predictive tests, and all predictive tests are usually through clinical genetics, or they should be. And then mutation present, put that, oops. So mutation present, that corresponds to likely pathogenic or pathogenic variants that have been found. Mutation negative counts for a VUS or a negative result. If you've got a VUS in a patient, it's probably worth discussing that with clinical genetics as well, because if you've got a very hot VUS, it might influence what you're doing a little bit more, but it shouldn't be inputted as a positive on CanRisk. CanRisk and carrier status for Check2, ATM, RAD51C, RAD51D and BRIP1. They all assume that the patient is a heterozygous carrier, i.e. they've got one regular copy of the gene and one with the pathogenic variant, not that they've got pathogenic variants in both copies of the gene, in which case we'd call them homozygous carriers. So you can get homozygous carriers with the ATM gene, and they've got a condition called ataxia telangiectasia. They're at a very high risk of breast cancer and they're screened based on a separate protocol. You can also get CHEK2 homozygous that have got a higher risk. So any of those patients that sort of homozygous for those genes, the estimation should be coming through clinical genetics, and just ask our advice. As I say, at the bottom you can calculate. So if I go back to my examples, so here I'm going to press the calculate button. Here you can go through and check what was inputted, and I would always advise you do this. It's really easy just to do something wrong, but you can have a quick look at what's been inputted and whether it fits with what you thought you had inputted. And it also has a copy of the pedigree here as well. So just check that's there, and if you've inputted that someone's BRCA1 positive, that should be shown on the pedigree as well, as it is here for this individual here. So if I just go back to the pedigree to show you that better, so you can go back to your inputs here, and that's your calculated results. But if we go to the pedigree here, you can see it's clearer. This patient here's had breast cancer at 35, a second breast cancer on the other side at 38, and she's been tested and is found to be BRCA2 positive. I've also got a prostate cancer in here at 75, an ovarian at 58, and her mother breast cancer and a maternal aunt at 50. So always worth just checking that you've got as much information as you expected to have. If we go back to the results here, when we've got the results, they've got multiple tabs. So they've got a breast cancer tab, a nice risk category tab, an ovarian cancer tag, pathogenic variant tab, your inputs and advisories. So if you've got somebody on the pedigree and you've not put their age and year of birth, it will alert there. If you've not filled in other essential information, it will mark it for you there too. It gives you the chance of developing breast cancer in the next 5 years, 10 years, and up to the age of 80. So this individual's got a 5-year risk of 9.8%, a 10-year risk of 17.3%, and a 40.4% risk up to the age of 80. It will give you a diagram here, a graph showing their risk, estimated risk, against a dotted line of the population risk. If that patient has already had breast cancer, that dotted line will represent the chance of a contralateral breast cancer based on that age of diagnosis, the patient's year of birth, and some other factors which I'll mention, but as I say, doesn't take into account what treatment they've had for their original breast cancer. It will give you the NICE category. So here it will tell you the 3 main categories. It doesn't have VHR on here. So it's got near population risk, moderate risk, and high risks, and the NICE definitions for this. And it also puts into a graph, and here you can see very clearly that this lady is in the high risk category, but as her potentially as her risk is over 40% here, may potentially also be in the VHR criteria. Ovarian cancer risk also demonstrated in the same way, and it will also show her chance of carrying a pathogenic variant, because there's a BRCA2 variant in the family. Obviously that's very high. Inputs and advisories. I'll just go back to my presentation. So as I say, different genes are taken into account with different risks. So the obviously genes that are not potentially associated, like BRIP1's not associated with breast cancer, but is associated with ovarian cancer, is only taken into account in the ovarian cancer panel. As I say, you can save the files. So it's got the save button here, and I'd really encourage you to do that. In our department, we have a particular way of saving it. We have pedigree numbers, which is like a family number, and then we can save it under the patient number. Those aren't patient identifiable as such outside of our department, because it's only within our department that we can use those. So you can we often download and save them based on their family history number. I wouldn't use an NHS number because that is patient identifiable. If that is the numbering that you're using within your department, I would download the file, and then once it's onto your own downloads within your own network, that's when I would rename it the NHS number. So as I say, you can save the file and you can save the report, or you can save the input. If you save the report, that's as a PDF file, and the save the inputs is that text file that I showed you with just zeros and ones and things on it. It's really worthwhile inputting this, saving the input file as well, because it just means that you can re-upload it and adjust it if something else comes to light, or you see another person within the family, then you can just change the proband, and I'll show you how to do that later, in which case it will pull over all of the family history information you've got and allow you to re-input lifestyle factors for the next person. This is how we save it in our department. So we have a CanRisk file, and we save under the pedigree number, and then we save under the patient number. You can, if you right click on the CanRisk file, you can pin to start, and then it will be down here for you, so you can very easily find the CanRisk file instead of just going through multiple different tabs to get there. So you can then use CanRisk once you've done that to calculate whether somebody would score up for genetic testing by using the mutation tab. So here's an example. So if we're wanting to test somebody using R208, we've got to have a 10% or greater chance of finding a variant. So for this patient in total, she's got a 12.47 chance of finding a variant in BRCA1, BRCA2, PALB2, CHEK2, ATM, BARD1, RAD51C, RAD51D, or BRIP1. Now, BARD1's not currently on our panel. I think it might be introduced in the future. And BRIP1's not on our breast cancer panel because it's only an ovarian cancer gene. So you've got to take those off. So you've got to take the 12.47% and then take off the amount for BARD and BRIP in order to get down to your figure. And then you can also round up. So if someone's 9.8%, you can round that up to 10% and they qualify. This person just qualifies based on a risk of 12.7%. So this can also be useful if someone's had a BRCA1, BRCA2 test in the past, but they haven't had PALB2 and all the rest of the genes. You can work out if they would qualify for a retest as well. And within our area, we have about a 6% threshold. If they've had BRCA1, BRCA2, or PALB2 in the past, just take off the ones that they've already had. And if the threshold reaches 6%, we can offer a retest. That will not be the case in the future for people that have had an R444.1. At the moment, they're only having BRCA1 and BRCA2 testing, but come the beginning, is it, of next month, PALB2 will be added within our region to that panel. Once PALB2 has been added, they're following the strict national guidance. There should be a 10% threshold. So the chance of you having a greater than 10% in the remaining genes is probably going to be as rare as hen's teeth, and we probably won't be able to offer that retest to most of the people that have had a R444.1 test. So as you know, NICE categorised screening based on population risk, which is a chance of developing breast cancer, a lifetime risk of up to 17%, or a 10-year risk between 40 and 49 of less than 3%, moderate risk as a lifetime risk between 17 and 30%, or a 10-year risk at age 40 to 49 of 3 to 8%, and high risk as being a lifetime risk of developing breast cancer of greater than 30% but less than 40%, and a 10-year risk between 40 and 49 of greater than 8% but less than 12%, and very high risk is a lifetime risk of developing breast cancer greater than 40%, usually due to a specific genetic abnormality in the woman or her family. And the VHR criteria are really complicated and nuanced depending on what gene, etc. So some ladies will just automatically go into the very high risk category. So if they've got a BRCA1, a BRCA2 or PALB2, they'll just automatically be in there. If they're very high risk based on family history or with one of the what we call moderate risk genes that is actually in their family acting out as a higher risk, the category is not as clear cut as 4%. So I would just discuss any patient like that with your local clinical genetics department. As I say, if you go onto the NICE risk category tab, you can see there what they will fall into, and most centres, if they qualify based on one of the two criterias, get that screening. So if one of them was in moderate risk and one of them was in high risk, most people would just give them what gave them the optimum amount of screening, although it's slightly debated between centres what you do there, especially if that woman, say, is in the 40 to 50-year-old category and has a higher lifetime risk, but her risk between the age of 40 and 50 is within the moderate risk section. As I mentioned before, if we're looking at contralateral breast cancer risk for a woman who's already had breast cancer, it will give you an estimation, but if they've still got a lot of breast tissue remaining on the affected side, that's really not going to be very accurate. And as I say, it doesn't take into account their breast cancer treatments either. For those women that have already had breast cancer, as I say, it will give you a dotted line, and that refers to the population likelihood of developing a contralateral breast cancer of a woman at the same age of first diagnosis based on general population data. It doesn't take into account anything like genetic variants, family history, or lifestyle or hormonal factors. So as I say, contralateral breast cancer risk doesn't take into as much information, lifestyle factor wise, etc., as you would hope it to do. So it excludes treatment details, tumour pathology, prognosis of the primary tumour, competing risks, and other limited data for contralateral breast cancer risk for other genes such as BRCA1 and BRCA2. The model assumption assumes that only the one breast remains at risk. So I wouldn't use CanRisk in isolation when counselling these patients. And although you're fine to discuss this with patients, you need to caveat the reasons. And if you've got a patient with a poor prognosis tumour, the risk of them developing a second breast cancer is probably not very high up their agenda. So I would always very much use CanRisk in those scenarios in conjunction with their breast cancer team. As I say, VHR screening is incredibly complicated, and I would leave it to clinical genetics or discuss anything with clinical genetics that you're concerned about. I have got a bit of a crib sheet for it, and I'm happy to circulate that if anybody would like me to, but sort of VHR and the screening for it is probably a separate talk in its own right. I would just bear in mind that if someone has a gene change in a gene excluding BRCA1, BRCA2 and PALB2, be cautious in mentioning MRI screening to them going forward without having that discussion initially with a member of the clinical genetics teams, just to make sure that they do actually qualify. So other top tips. So as I say, you can change the proband, and that allows you to use the family history information for somebody else. So if I just bring my example back across to show you that, and you decide actually you want to work out here we go, maybe this aunt over here you're about to see next. So you might pick her and tick this box here to make her the proband, and it will come up with this warning that basically you're about to change all the risk factors for everybody else. But you can make her the proband, and then you can calculate, and you can go to the result, and perhaps you want to see the chances of her having a pathogenic variant. And due to the fact that she's lived to a ripe old age, etc., the chance of her actually having a BRCA1 or BRCA2 variant within the family are relatively low. But that can be useful if you're trying to work out potentially whether somebody else in the family might qualify, or you end up seeing a sibling of the patient. So it's really handy to have that. And there's another reason why we try and encourage you to save the inputs as well. So you can just upload those files rather than re-enter everything. Population applicability of the CanRisk tool. So CanRisk has been designed for use in European ancestry because that's where they've just got the most data. Expected to work relatively well in other Western populations. You can select different populations. So if your patients come from Iceland, Poland, and some populations we know have higher frequencies of BRCA1 and BRCA2 variants, such as Iceland, Poland, and the Netherlands. The frequency of picking up mutations in those genes can be adjusted to allow for that. The CanRisk tool is not particularly great if your patient comes from an East Asian or developed country background, and it's particularly less reliable in sort of calculating cancer instances in those populations. So as I say, in the BRCA, you can change the pathogenicity variant frequency up here, and it allows you to select UK, non-UK, Ashkenazi, Jewish, and from Iceland. But remember, if you do change it, next time you use CanRisk, you need to go back and put it back to UK population. You can also change the specificity of picking up a mutation, so the chances of us picking up a BRCA1 variant, if there is a BRCA1 variant. These sensitivities are actually quite low currently on CanRisk, and probably represent quite a significant underestimation of our chances of actually picking something up. However, I would say I wouldn't adjust these figures. Some genetic services do adjust these figures locally, but I've sort of pushed more and asked CanRisk more to adjust it themselves, because I feel that if we're all going in there and changing to different specificities, that's not uniform across the country. But as I say, that can be done if you want to. How can I avoid underestimating the risk? As I say, it's really important to input a pedigree completely, accurately, and up to date. We appreciate that often people don't have huge amounts of insight into their family history, but try and estimate things where possible to ensure that those relatives are included. And as I say, it's really important to just go through and check the inputted data and make sure you're happy with it. And as I say, all individuals with the cancer must be recorded with an age, a diagnosis, an age currently, a year of birth, or year and an age of death in order to be included. If a family member's had a prophylactic mastectomy or oophorectomy, it's advisable to set a current age at the time of her operation, assuming that she subsequently remained cancer free. So if you've got a sister who's had a mastectomy at the age of 35, I would put her in CanRisk as having died at 35, which seems a bit harsh, but in order to best estimate the risk for the person sitting in front of you, that's the best thing to do. But obviously explain that to the patient if they're looking at the family history. Include as many genetic test results as you've got, and if a family member is of Ashkenazi Jewish origin, it must be recorded, as they have quite high rates in that population of BRCA1 and BRCA2 variants. As I say, you can load up your pedigree, your family history from other software as well. So either a previous CanRisk file or certain pedigree drawing softwares can also be uploaded. And I think Phenotypes is one of the ones that's typically used. The mutation carrier probabilities in families of members that have 2 or more mutations, or families with mutations in more than one gene. So the model doesn't allow you to take in combined factors. So if you've got a BRCA in the family and a CHEK2, it will assume the highest risk gene and just calculate based on that. And this is the scale that it uses. So a BRCA1 will trump a barred one, or a BRCA1 will trump an ATM variant. The risk will just be based on that dominant gene. And the same for ovarian cancer, but obviously less genes involved with that. I think maybe with further additions, we have more knowledge that will be corrected, but it's worth bearing in mind, especially if you've got multiple different genes in a family. Troubleshooting, yeah, sometimes you just look at your CanRisk and think that doesn't look right. If that's the case, ask your colleagues, ask your local clinical genetics. CanRisk are actually really helpful at replying to emails. If you email them and say, well, why is this calculating this? There's there's a few things to be aware of, like obviously if your patient's above the age of 80, it won't calculate a cancer risk. If your patient was diagnosed with breast cancer over the age of 80, they won't be included in the calculations as well. Some things that are a bit counterintuitive, so you assume a high BMI before 50 is increased risk of developing cancer, but actually it has some protective effects up to the age of 50, but then increases the risk over the age of 50. There's been some national guidance based on how to use CanRisk, and this was based on a consensus meeting with multiple sort of stakeholders that went to make up this guidance, and it has been published. But as part of this consensus statement, basically everyone agreed that we should be using CanRisk in order to estimate breast cancer risk for patients. They provided some guidance on what they felt that should always be put into CanRisk when assessing somebody's risk. So that's helpful, and some additional information on what should be discussed with patients. Okay, I think that's the end of my slides.